Welcome to Elimination Exchange, a podcast from the Global Institute for Disease Elimination, GLIDE, here in Abu Dhabi, where we dive into bold conversations at the intersection of equity, innovation, and the fight to eliminate preventable diseases. My name is Simon Bland. I'm the CEO of GLIDE, and I'm your host for today's podcast. For this episode, I'm thrilled to be joined by Sir Peter Piot, renowned microbiologist, global health pioneer, and one of the key figures behind the response to some of the biggest health crises of our time. I also count him as a close friend. We'll be unpacking what we're calling Global Health 2.0 or 3.0, a new era that demands more than just technical solutions. It's about shifting power, rethinking global structures, and putting countries at the forefront of their own health systems and futures. What's changing in global health and what still needs to? What does true country ownership look like? And how do we build systems that are community-led and sustainable? Well, hi, Peter. It's so great to have you with us today, and thanks for making time. It's always great to see you. I thought we had such a good discussion a couple of months ago, and I thought it would be really useful and helpful to catch up again now and really share some of your insights and thoughts with GLIDE and with the global health community. Thank you for all you do. Thank you for all you do in global health, and thank you for all you do for GLIDE. It's great to have you as part of our technical and advocacy advisory group. You and I have known each other a while, I think 2.5 decades or so now. I remember, Peter, meeting you for the very first time. I was leading UK development program in Russia, in Moscow and Ukraine. Right. You were heading UN AIDS, and that was the very first time I met you. And we've bumped into each other many times since then at Global Fund and UN AIDS and Gavi. And I have vivid memories of your visits with Suma Chakrabarti to Kenya.
Oh, yes.
You remember going to those AIDS orphanages. So you've seen a lot. You've helped me see a lot. And it's a real pleasure to have you here. So thanks again, Peter. Nice to see you.
No, great to see you again. And also after, a quarter of a century, to put it that way.
Yeah.
And also, I think GLIDE is fantastic because it's part of the new global health ecosystem that's been building. And thanks for everything you've done. So let's continue the collaboration.
Thank you, Peter. So that's a great segue into that. So, 2.5 decades, 3 decades, we've seen enormous shifts. I think I've heard you talk about Global Health 2.0. I know we both remember global health before there was any money, and then we've gone through sort of probably what was peak development. And we've seen massive changes over the last 6 months. So it'd be great to start with your characterization of those changes with a real focus on the changes that are happening right now.
Yeah, Simon, before doing that, I would say let's not forget that there has been enormous progress in the last 25 years. I mean, real achievements that are very hard, in 25 years since 2000, because that was a turning point. Let's not forget the term global health did not even exist in the last century. But the under 5 mortality, so children dying who are under 5, has been halved in 25 years. That's an enormous success. People with HIV can now be treated. It's no longer a death sentence, and so on. There are many aspects of health that have been improved. And it's in the first place because of domestic investments and of, local action. But also, I think the international community has contributed in particular sectors. When I think of HIV, for example, that's for sure. Now, I start wondering whether the last 25 years wasn't kind of a historic anomaly in the sense that, funding for global health, international health funding, was rising slowly at the end of the 90s, particularly driven by HIV, the HIV terrible epidemic. Let's not forget, in these days, there were more than 2 million people would die every single year. And so that has been, between 2000 and then now, with the creation of the Global Fund to Fight AIDS, TB, Malaria, the President's Emergency Plan for AIDS Relief in the US, Gavi, the Gates Foundation. So a lot of money coming in, and then with a peak around COVID, but then it already went down slowly. And now suddenly we have a combination of the abrupt decline of U.S. funding, and let's not forget that the U.S. was the major funder for for global health initiatives, particularly through its HIV programs, PEPFAR, but also malaria, TB, and so on. But also that European donors also have seen a major decline. I mean, 40% decline in the UK, and then many EU member states, 25%, and that's due to a combination of factors. One, the war in Ukraine, and a lot is going to defense now. Secondly, populist movements often who are against international development on taxpayers' money, and also I would say the emergence of a more multipolar world, which is a positive thing. So I think that we are on the one hand, an acute crisis in a sense, but on the other hand, also at times of great opportunity. Plus, let's not forget, as I've been talking about it, and you alluded to it, for years I've given one of my speeches was the need for Global Health 2.0. We needed to change, crisis or no crisis, in terms of funding. And I just didn't think it would come so abruptly. But on the one hand, sometimes I would say a crisis is the only way to induce change, certainly in bureaucracies.
When you talk about crisis and opportunity, I guess we both sort of look at this with some sort of combination of concern, but also strategic curiosity, as in what might this moment mean, this crisis and opportunity. So how do you sort of counterbalance those forces? So what sort of impacts do you think we're seeing in communities, and to what extent do you think this might force a rethink?
Yeah, Simon, I think this undoubtedly there will be some impact in terms of lives and deaths, because particularly the US was very directly engaged in organizing, for example, HIV treatment. Although it's not going to be completely lost, I think the most immediate impact could be on malaria, because when there is the rainy season, and and there are not enough bed nets or treatment options or prophylaxis, we may see an immediate rise of deaths, particularly in children. TB also will be affected. However, I think that some of the predictions of the millions of deaths assume something that I find is really an indicator of what is wrong with global health. They assume that no government will act, and that it's all the progress is due to international funding, and that's not true. And what we're seeing is that there is reactions. Countries are, sometimes with great difficulty, trying to find money. One of the big problems, particularly in sub-Saharan Africa, is the enormous debt burden, which means that the fiscal space for dealing with health is limited. But you can also argue that it is really the responsibility of governments to make sure that the citizens have the best possible access to healthcare. I know this is limited because of the fiscal aspects. And so what I see as on the positive side is that there is a growing not only awareness, but also a growing putting in place of measures. It's very country dependent. And I think the biggest mistake would be to say, okay, we need to fill the gap and continue as usual. Let's not forget that some of this, international support to health was quite expensive. And that I believe that, because of the middlemen, a lot of this so-called aid is channeled through European or particularly American organizations with huge overhead costs, and rather than to use local and far less expensive organizations and businesses. And so I think that what's clear now is that the countries, the governments that are addressing the collapse of some of the foreign aid are now setting up local systems. That's going to take time, and I hope we will have a couple of years to to get a new systems in place. It seems to me that, for example, for HIV with PEPFAR, that there will be space for that, particularly for treatment, not for prevention,
Right.
And perhaps for malaria also and TB. And I think in 2-3 years' time, it is and should be possible to have put systems in place that are probably more cost efficient. And but in the meantime, we have to make sure that the damage is limited. So my response to people is when there's panic, I said, well, don't be depressed. That's a waste of time. Forget it. You can be angry, fine, when you take your shower, but then turn that energy into working on longer term solutions and a different way of doing business. And that is the stage we're in now. That's not just theory, but that's what is going to happen in more and more countries.
So we've had this progress. It's largely been driven by domestic investments, as you said, and global health and international investments has played a big part in that. And there's been a heavy reliance on the US, the UK, Gates Foundation, and others, but a heavy reliance, and that has shifted quite massively. I've heard heads of state and ministers of finance and ministers of health say, as you've heard, this is a wake-up call. It's time for us to do something different. I think you recounted to me a conversation with Mohammed Pateh about how they could do things so much more efficiently, and cheaper.
Right.
So I think we all feel that's the transition that we need to see. And I guess the question is, should we stop using the expression donors? I really dislike this donor-recipient language, and I think now is the time for us to be thinking about this as investments, but common investments in common goods. I don't like that dynamic.
Thanks for asking that question. So you remember we were both on the board of the Global Fund. You were even chairing it. And from actually the very beginning, I several times I objected to this term. We had the donor constituency and the recipient. And it's only quite later, I think, when you were the chair, that terminology changed slightly, but still not.
Yeah.
And I think that we should stop with that. And it's like also in academia, I said, there's also these terms, my site in the Gambia or my site in Kenya, whatever. I think that's no, we have to go to partnerships, but it suggests that all action is thanks to the donor. And that's not true. There is a recent study done at the World Bank, and it shows that when you look at the contribution of international funding to health outcomes, it varies. It goes from like 1% to maybe 50%, because in some cases, particularly for HIV treatment, there, in a sense, the governments have not taken up their responsibility very often. But I understand that if I were the Minister of Finance and someone comes and gives me 20 or 100 million a year to deal with a real big problem, that's great. So I can use my money for something else, because the pressures on governments are enormous. But I think this, donor recipient, that should be the past, hopefully. And when you look at the multilateral organizations or the bilateral, I see it more as supporters or as enablers, as Peter Sands used that term, I heard him, which I like also for certain things. And it is also, let's not forget that the donors have also are at the same time recipients, because a lot of the money goes to institutions, be academics or NGOs or businesses in the so-called donor country. And it's a whole industry that is actually benefiting from that. So there's a lot of money that never reaches the actual so-called recipient country. That's another issue. that's probably okay in the sense that, you have an enlightened self-interest. And I think that a silver lining of the COVID pandemic has been that certainly in sub-Saharan Africa, or in Africa itself, that I would say for the first time, there wasn't kind of waiting for charity from the North. One, it didn't come anyway, because there was a huge epidemic everywhere. And what I saw was leadership at the level of the political level. African Union was President Ramaphosa, who was then the chair, and he took on things. Africa CDC had just been created after the Ebola West Africa epidemic affecting 3 countries. And they were really organizing themselves and negotiating with the companies and with pharma and diagnostic companies and so on. And I think that was a turning point for me. And that, I think, also changed the, the paradigm. In a sense, I love to quote Bob Marley, he's one of my favorite singers, so emancipate by yourself from mental slavery. Just no longer waiting. We can do it ourselves. And I think that is now, that's leading also to, for example, a whole movement to promote local manufacturing because, we can have pandemic treaties and so on. And of course, I'm very supportive. However, when there's a huge crisis and the scarcity of the means to fight it, scarcity is one of the biggest enemies of equity. So then each country, each head of state or head of government will give priority to his or her own citizens, because democracy, that's who you're elected by. And so the only solution is not going to be a treaty, which will help, but it is having the products where they are being consumed, where they're needed. Not in every single country, but we see this movement for manufacturing in Africa. Okay, vaccines, which is the more difficult ones, but I hope and trust that soon, like in a country like Nigeria, dual bed nets will be produced. I mean, Africa is like 90+% of the market, but not a single dual bed net is made in Africa. There are other bed nets. So I think this is, and this in addition will create an industry, provide jobs, because their talent is there, but the job opportunities are not there, the industry, the investments. So I see this as a whole kind of a movement that is happening at the same time as this decline in international development assistance, as it's called, the
Yeah, Peter, thanks. And they should mutually reinforce one another. I think that's right. And there's a couple of things I'd like to talk a little bit about, sort of location and that local manufacturing. But you talked about ministers of finance, ministers of health, the fungibility of resources, basically. If you're going to put a lot of development assistance in health, what space does that create? And it clearly created space. I remember a conversation with one minister of health talking to one international organization about things they didn't like about the grant, and the institution said, well, we're a demand-driven organization. If you don't want the money, don't apply. And I thought, this Minister of Health has no way at all of not applying for $500 million. It would be irresponsible of them not to. So it wasn't genuinely demand-driven. I guess and I also heard Naveen Rao from Rockefeller at World Health Assembly talking about, and you talked about it in many ways, donors being supporters, donors being on the periphery, and this being much more sort of country driven. So I guess the question is, one, how confident are we that shift in decision making and priority setting will happen? And secondly, how do we help it? How does a little organization like Glide, but how do people like you and this community really help promote and push this transition?
So this is where the opportunity is now. Because organizations don't change easily or spontaneously. And there's also, I should say, quite a failure of multilateral governance, where the accountability of those who are in the boards it's not. They haven't been really thinking this through. They should have seen this coming, and they should have taken this on. So accountability of the organization that is no longer meeting countries' demands. So that's where the opportunity is at several levels. I mean, on the one hand, we talked just about manufacturing, but when you see in Nigeria, there is a presidential initiative on the healthcare value chain, and that is really trying to take innovation and manufacturing in the country. In Dakar, Institut Pasteur Dakar, they just opened. I was there in December. A big vaccine manufacturing set, and I could go on. There's so many opportunities. So these are all initiatives. Some will fail. There's no doubt about it. And then that, of course, will reinforce those who said, I told you so. They're not ready. But that is normal. But then I think that the need for change in the multilateral system or in the aid organizations, I think will probably only come if because of this financial crisis that they're exposed to. Because it's not been going, spontaneously. But when I see, for example, you mentioned the Gavi replenishment, there was a statement by European donors, Japan, Australia, and Canada, where they said, yes, we're supporting, but conditional to radical, they even use the word radical reform. Not only Gavi, because Gavi has had a fantastic impact, there's no doubt about it, but also, the Global Fund, etc. I mean, when you look at it, that they're doing their business all over, particularly in the low-income countries, but they're all based in one of the most expensive places to do business, Geneva, in one building, each with their own human resources, procurement, etc. Unitate is also there, created because the French wanted their own institution. And then, with different cycles for funding, which puts a big burden on countries. And the separate monitoring and evaluation systems, but that's no longer sustainable. And I think that in this case, it will only succeed and meet the needs of the people we claim to work for. Improving health outcomes is, at the end of the day, in this case, is what we are all about. If that movement is driven by those countries who are affected in the first place, together in partnership with, let's call the ex-donors, still hoping that they continue, but the wealthier countries, but also new entities. I'm particularly thrilled that UAE, that in Abu Dhabi, there is a fund. Now, there was Glide, you were a pioneer, but now also there's an International Development Fund.
Yep.
We have India getting more and more active, of course, China, but even Singapore, Indonesia, Brazil. So this is a different world, and I think that will make it also a better world, because we will have also not just a single approach to health, but also something that is based on different approaches. And what can we do? I think enabling or supporting. But I would say that my concern is that these discussions should be based on what is the most useful for achieving health outcomes in, I would say, in the first place, low-income countries. Because let's not forget there are some countries that are today even high-income countries. Take South Korea. South Korea was at the GDP at the level of, and Singapore also, of Ghana when they became independent. And now they're among the richest countries in the world. Look at the Gulf states also, etc. So, but the low-income countries, they will need support for a long time, but it will only lead to sustainable, efforts and sustainable results if that's done according to their priorities within their systems. And so we need this kind of alliance. Now, it has to be, of course, there has to be leadership for this, but all these organizations, I'm not talking about the World Health Organizations. The world will always need that. Yeah. That's a different story. We need that's normative function, not the rest, but the normative function we need, and the convening, for everybody. But other funds specifically, they should have a sunset clause. But it has to come from the outside. It can't come from the inside. And that's not a matter of individuals, but that's the nature of the reform we need. It's not just a reform, it's a real change. And frankly, WHO needs that also, but the governance is intergovernmental. That's far more complicated. I won't comment on that. For me, the key there is focus on your core business. Otherwise, the risk is to become irrelevant. And getting out of Geneva, honestly, for most of these organizations, there's a big world, and I would go there where the action is, and where it's far cheaper to do business.
Thanks, Peter. So a couple of reflections. I actually thought the Gavi replenishment was better than it could have been. Tanya has to be incredibly pleased with what she's done. And I'm desperately hoping that doesn't make people think, don't worry, everything's going to be okay. We're going to go back to the way we were, because I think that's a huge mistake. I think there are real opportunities for countries to take a much stronger leadership role, for us to play a more supporting role, and I think that's a bit of a challenge. So as people are lobbying and advocating in the US for return, I'm saying, well, yes, but not to the way it was. So I think we have to demonstrate that it is Global Health 2.0 or 3.0, whatever, but it's going to be new and different.
No, I totally agree with you. But I think that I'm also concerned that the relative success of Gavi replenishment could lead to complacency and said, it's not too bad, we can continue. Now, even without this, funding crisis driven by US and EU countries and UK, we need a change. The status quo, continue as it is now, is really not an option. It will, then what we will have is an agony and kind of palliative care, and of course then these institutions will, they will continue to work for quite a while and employ a lot of people with good salaries for a while, but that's not really going to make a sustainable impact. And I think that this is where the engagement of new countries, I mean, you mentioned Indonesia or Nigeria, but also I would say Brazil. And also that's where, UAE can, and other countries with the new, as a supporter of health programs in other countries, can do it differently. And not just use the same approaches and leading by example. And then that's where smaller, contributors can really make a difference. But it will. I think this is where the boards of these organizations will have to take up their responsibility. But I'm I feel in the corridors people make all kinds of very good statements. And we need to change, and then when it comes to the actual board meeting, not much is happening. So there will have to be pressure from the outside, and it is going to come. We'll hope that the replenishment of the Global Fund to fight HTB malaria in November will be equally successful. But I think in both cases this will be their last replenishment, I assume, and I think that in the future. I can see a few developments. One is that a kind of a merger between the two, and also Unitate in there, in some kind of holding company, and where everything is harmonized and so on, so that the burden on country is different, but also that the governance is changing, and that because that's key also, and that the accountability should now be in the first place to those societies, countries, populations where the action is. That's the number one, accountability. And for example, to have their multiple funding cycles, that they're harmonized and that they're completely in sync with the planning cycles of whatever country they're working with. And that they should also be making sure that they support the systems. So I think that this is really in the first place a political issue, where the role of people like you and I think, is more to make sure then that the decisions are based on the best possible outcome, because we need to think also about the best return on investment. Now I think more like a business. I've been working a lot on HIV in my life, but when you look at HIV, it's a huge issue still, particularly in Southern Africa, East Africa, and here and there, and it's going up in some parts of Asia and all that. But in other countries, that's not what the main issue is. There are others, and it can be malnutrition. It can be some so-called neglected tropical disease. You don't know. So it has to be far more tailor-made to countries. But for me, I would say that what we can do from the, let's call it, international community is, besides supporting and enabling what the priorities are, and making sure that these multilateral organizations take the country leadership seriously, but also that there is, that we continue to invest in innovation in that can be used to have better and results, more cost effective, and that innovation also. The time is gone that all the innovation happened in the US or in the global north. The good news is now that there is no longer a total hegemony of one particular country,
right.
The US in certain areas. So it will be more it's a multilateral, but multipolar, and that is an opportunity for, again, to give a voice to the countries concerned, but they will have to also make sure they have accountability and they take on their issues.
Yeah,
that's very important.
It's really helpful, Peter, and it's the words are sometimes easy. The actions and implementation is hard. You talked a little bit about the UAE, a supporter of health. It could do things differently and lead by example, and I'm certainly talking about that here in terms of how do you genuinely put countries at the center? How do you genuinely experiment? How do you take risks? How do you trust more? But you still have to account for resources, So it's mutual accountability. It's a partnership.
Yeah.
No, it's not just a relinquishment of, everything. Well, here you go. But equally, I think with philanthropy particularly, you have a little bit more latitude to do things differently, to be a little bit more experimental, to have some different risk profiles.
Yes.
You've talked about technology. You've talked about where centers of excellence are, where many of those. I see so many of these innovative ideas don't come from the so-called north anymore. They come from where the action and the problems are. People deal with these things all the time, and they find you've lived and worked in remote and difficult places. You see people's ingenuity, and so how do you harness that and tackle that? How do you see AI particularly, but technological advancements helping us move in that direction that we want to go?
Yeah, no, I totally agree with all that. I think first on the tools, there is a fantastic pipeline, and vaccines, even for TB and so on. And I know that not everybody is convinced, but vaccines have saved millions and millions of lives, and not only vaccines for children, but also now for adults. So we'll see new and better vaccines that's going to save lives. The key will be make them affordable and accessible. And there will be probably, let's not forget that the biggest, causes of death now in many countries increasingly are so-called non-communicable diseases. I mean, diabetes and obesity are getting out of control in many countries. This is no longer an issue for high-income countries only, for the West. No, cardiovascular disease, stroke. I remember the hospital I used to work in Kinshasa, the Mamaimo Hospital. When I was there, it was full of patients with AIDS, dying all that. My age in these days. And then about 10 years ago, I visited again. And, it was in internal medicine where lots of fairly young people with stroke
Yep.
with all kinds of cardiovascular diseases. And now when you look at, you go either, is it in India or in South Africa, diabetes all over. Kenya, just name it. So we need also affordable strategies for that. Of course, it's a matter of, the prevention. That would be the number one. But there is going to be good technologies. GLP-1 antagonists could be maybe like we take statins. Who knows? So I foresee in the next 10 years quite a revolution as long as it's affordable. And so that means that we need to work also on this access and local production and all that. Let's not forget that Africa will be a huge market, and that there is a middle class emerging.
Yes.
Just as India now and China have a huge middle class, hundreds of millions, with purchasing power. When we see that for HIV now, with 2 injections a year, you are 100% protected. We may go to 1 injection a year, or we may have oral, prophylaxis and so on. So that's one. And then I think that AI is maybe the place or the tool for leapfrogging. And I've been very impressed. This was the first time I saw it was at the Grand Challenges meeting with the Gates Foundation in Dakar was 2 years ago or 2.5 years ago, where there were entire sessions with all young Africans and coming up with their AI programs and all that. I think we're going to see a lot of that going, that will not solve the problem. Let's not be naive. But for diagnostics, particularly when it comes to imaging, would make births safer, better diagnostics, but also the whole system of the management of the fiscal system will be really improved. And I think because there is no system that will be resisted, there we can go to really much faster adoption of innovation. Just as the mobile phone was, there's still no landlines in the places, but the mobile phone, that was the leapfrogging. And when you look, who was the pioneer in the world for payment by mobile phone? Kenya. M-Pesa.
I was part of that. Yeah.
Yeah. So that was it was not Silicon Valley, or China. No, it was. And so things like that are going to come up, and that I hope will also pull a lot of people out of poverty, and it will also hopefully provide us with better data and good data system to assess whether what we are doing has any impact, where the priority should be, etc. Because that's something that we all that we may lack in the future if we don't set up new systems, and that's where AI and the mobile phone, this combination, can really make a difference.
So you're right. I was in Bangladesh in the late 1990s working with women's groups. They got market intelligence by text message on there. They weren't smartphones, they were the old phones, but they got text.
Yeah, not smartphone. Yeah, exactly.
I'd go back and talk to family in the US and they thought, text messages? What are text messages? They had no. So it's a world that is, I think that leapfrogging is something that's really exciting. I know time's getting short. It's just always wonderful to talk to you. A couple of things to make. You said a couple of times, you said so-called NTDs and so-called NCDs. We deal at Glide with some neglected diseases and malaria, and we deal with elimination. Maybe you could just give us a few thoughts about, one, I'd like to stop calling them NTDs. I really would like to think of something else like your thought. I think I've heard you talk about that in the past in Nagasaki and other places. But I think, and your thoughts on, we think a lot about elimination, right? We care about elimination, but elimination is not easy. It's not straightforward. There are increasing numbers of country examples of elimination, differently defined. And that's good news. The map is shrinking, but I worry that, the opportunity costs of dealing with this are a challenge. But just great to get some of your thoughts around that NTD, NCD, and burden reduction continuum through to elimination, and any advice you have for us at Glide would be helpful.
Yeah, when I said so-called, it's because I don't like these acronyms.
Right.
And indeed, non-communicable diseases are often have a viral origin. Okay, I'm an infectious disease guy, but also when you define something with starting with none, it's a non-issue. No, that's not a very good communication. So I usually talk about chronic conditions, etc. But anyway, they need to be more on the radar screen of the global health community. But I think with the neglected tropical diseases or infectious diseases, they have been neglected, that's for sure. But what I like about them in the sense of the movement and what you're doing is that they are quite real, some of them realistic targets for elimination.
Yeah.
Which is not the case with, diabetes or HIV. For example, there's no way you can eliminate something that is sexually transmitted. But because it's let's call it evidence-based optimism, because there are countries that have really eliminated some of the warm infections, helminthic infections, or guinea worm. Let's not forget. I mean, that's quite a success story. What we know is that the so-called last mile can be the last 10,000 miles. Look at polio. That is, and so this is the. I think we need to make a distinction between elimination and eradication, but that's and the tools are there in most cases, and they're not expensive. But a lot is to do with education and with having really consistent efforts and campaigns often, but also part of the system.
Great, Peter. Thanks. There's lots more we could discuss. Well, where will we be in 5 years? What's your and 10 years?
I think that we'll see probably a number of countries, a growing number of countries that are really will have, let's say, the classic infectious diseases very much under control, not eliminated, but where HIV, TB, malaria are no longer really problem. That some of the neglected diseases will have been eliminated. I think we'll see that, but other countries may even be worse off, and that is, in the first place, depends on whether they're in conflict. And let's not forget, without peace, it's not possible to have serious progress in health and education and everything. And that is a big concern that I have with growing conflicts, and some of these conflicts are chronic, so that is a big issue. But then secondly, we'll have innovation. We have new tools. I hope that AI will support the development of genuine, affordable health systems, that will help. But then thirdly, I think we'll see a tsunami of chronic conditions, cardiovascular diseases, and something like hypertension that's manageable.
Yeah.
And the prophylaxis of it, prevention, is very affordable, but it's not on the agenda. Diabetes and so on. So that is going to be a huge problem. But I also see that there will be the role of high-income countries in supporting it will have changed. I think we need to be realistic. It's not by closing down everything that's on the international health support in, let's say, in 5 years, in 2030. But the big issues are what some call the fragile states, the countries in conflict and all that. That I'm very worried about. And they're not only affecting their local populations, but also the surrounding countries and refugees and, huge expense for defense that cannot be used for health and education and so on. But I think overall, I'm optimistic.
Thanks, Peter. Well, I hope I am too. If you are, it makes me more optimistic than I would be otherwise. So I lived on the on the border of Mozambique. I think that war was 16 years. That was chronic, and you see what happens afterwards. So you're right. You know, it's there's no prosperity, there's no development without peace. Massively important for all of us. Peter, look, as always, it's such a great pleasure to talk with you and learn from you. Once again, thanks for everything you do for us and for everyone else. You're looking really well, and just once again, thanks so much for your time, Peter.
Thanks, Simon, and thanks for everything you're doing. It's a great job. Thank you.
Peter, thank you for joining us, and thank you to all our listeners for listening in and watching in to this podcast. If you want more information, please find us at our website at glideae.org.